So my name is Hendrik Rosewich. I'm from Germany. I'm a pediatric neurologist there. And I was engaged with AHC almost 10 years ago because we had 2 patients at our hospital, and we were really interested in how and what would the primary genetic background of this disease would be. And we did a lot of different trials. So we did candidate approaches, candidate gene approaches, and then when next generation sequencing techniques pop up more, we did a what we called probe and parent trio approach in 3 of this, and we were lucky that there was one mutation that we found in 3 children and not in their unaffected parents, and then we went back to our whole cohort that we collected over the years with the German research, with the German AHC Patient Foundation, and then we were lucky that we found a mutation in the gene identified with this next generation sequencing techniques together with the University of Cologne. I know personally, of course, this meeting I got to know many more patients now, but I know personally around 40 kids. They have a huge age spectrum from 2 months to almost 30 years. And I think the symptoms that they have are quite different. And we have a little girl, she is attending regular school, and if she has not her spells, she's really doing good. She has almost a little ataxia, and this is it. And then, of course, we have these really severely affected ones that have persistent neurologic deficits, like they have ataxia all the time, and they have a severe dysarthria, they have a bradykinesia, they have postural instability, and all this. And I think worst part of all of this is that you can't say what's happening next. So they always wait for something to happen, and I think this is really what makes it difficult, because I think when I would have a kid with AHC and I think of daily life, just going to the supermarket or something, and my kid would be fine, and then out of a sudden it has a severe episode of hemiplegia or even quadriplegia and maybe respiratory distress also. I think that must be very hard, and you just, if you are a mother or a father, you just can say, okay, let's be at home, let's just have regular life. You just have to face with all the problems and all the things that that are just happening. And I think this is the most difficult part of dealing with AHC patients. And that's why I'm really into it. I told it yesterday in my talk that I was, I don't know if it's the right term for it, but it's somehow a fascinating disease, because children can be without any symptoms and they can be that severely affected. And then you have this huge phenotypic spectrum that even reaches out more than over AHC to this adult-like phenotype, like rapid onset dystonia Parkinsonism. And then very recently, the identification that another syndrome is linked to mutation in ATP1A3, which is called Kappa syndrome. It's amazing how huge this phenotypic spectrum all in all is. And I think that makes it even more interesting and even more, stresses me really to concentrate on the pathophysiology of this disease to find something. Because I'm quite sure that maybe in the next years we won't find a cure for this disorder. I'm quite sure about this, but I think just to reduce the spells, when we think of HC patients, would tremendously improve quality of life. Or if we have the spells, if we find a really effective treatment to stop it right away or to alleviate the symptoms, I think this will really help daily life. I think the typical attack is that out of a sudden we know that there are certain trigger mechanisms like physical stress or emotional stress or even sensory stress like water pounding down on your body, they out of a sudden show symptoms like you can compare it best, I think, with a stroke. So they really have a one-sided hemiplegia, so one side of the body is really without any function anymore. And moreover, they, in addition to this, they were not able to speak anymore, and they were not able to swallow anymore. And sometimes this hemiplegia then changes to a dystonic spell, which seemed to be, for at least some children, be very painful. And I think when it starts with the hemiplegic episode, the children are sometimes they are really frustrated because they want to do something and they are not able to do this anymore. One father told me a nice story of his daughter. He said, you know, the best moments and the nicest moments are the worst enemies of my daughter. And then I talked to her and she was laughing because I made some fun with her, and then out of a sudden she got a somehow severe hemiplegic episode, and then I know what he was talking about, and this is even more sad, I would say, because laughing can trigger a hemiplegic episode, and this is really kind of sad, I think, because the overall thing is quality of life, and this affects quality of life a lot. When I think of my own life, of my personal life, not being able to laugh without having maybe afraid of getting into such an episode, I would be really, really sad. And this is what you see in the older AHC patient. I think this hemiplegic or even quadriplegic attacks are not the main problem anymore. I think afterwards they're really behavioral problems like depression-like problems that all comes out from frustration, and this is a really sad thing too. But these kids are out when they are out of their spells. I think these kids are really special, and the ones I know, there's a very special contact right from the beginning. Yeah, and this is somehow interesting. I can't put it in words, right? But I have a special feeling that you get in contact somehow in a different way than you would get with a healthy child or a child not affected by this disorder. We learn a lot. I think when we think of treatment, we don't only have to think about medications, because we were able to identify a really special girl with a private mutation not described before. Then that really she whenever she has a spell, just closing her eyes was able to stop the spell. And maybe we will find more of these factors, I would say, or negative triggers to just prevent or to just stop the spells. And I think flunarizine or Sibelium just did a good job for the last 20 to 30 years in reducing the frequency and the duration of the spells for many AHC patients. And I'm quite sure that the already ongoing screening for drugs that can positively influence the function of the protein that is deficient in ATP1A3 will come up, and we will have clinical trials, I think, really in the next 5 years. I don't know, as I said before, I think they might help to alleviate the spells, they might help to stop the spells, but I think to find a medication or a drug that really helps with the persistent symptoms will take a lot more. And if we can learn from the other phenotypes like rapid onset dystonia, Parkinsonism, where you have a dystonia that is not coming and going, that is fixed to one side of the body over the whole period of life after a sudden onset, we have to identify what's happening there, because that must be something different to the patient with alternating hemiplegia of childhood. It seems that something is destroyed there. I don't have a better word for that. And we really have to prevent this to happen to AHC patients, and we really have to figure out what's the difference in between. And if we understand this, and this is what your question I think also means, is if we really understand the pathophysiology of this disease, the speed for finding a cure will tremendously increase, because then we can really look for the mechanisms that cause these symptoms. And I think it goes to what we call in Europe at least personalized medicine, because I think the different mutations that are seen in these patients show up with the different mechanisms. Like maybe you have the protein produced, and maybe it's simply not functioning proper. But another mutation might cause that the protein might not be processed to the cell membrane, and another mutation might cause that a protein might not interact with the common interaction partners it had, and so on and so on. Might influence the electrophysiological properties of these ATPase, and so on. And I think maybe the treatment will then be more concentrated or focused on each patient, depending on the mutation and, of course, depending on the consequence of mutation. But this is future music, but I think we are getting closer and closer, especially because ATP1A3, the protein, is almost exclusively expressed in neurons, and all the tests we did, we were just what we call heterologous expression. So you take the mutation and put it into a cell type and make the cell to express the protein with the mutation, and you see functional differences. But what we want to do is to be really in the system that is affected in AHC patients. So we are happy to have this amazingly method of inducible pluripotent stem cells. So we took skin from AHC patient and were able to reprogram them to a type of cell that can easily be, not easily, but can be differentiated in any other cell type. Like you can do skin again out of it, you can hair, you can make a tooth out of it, but you also can make a neuron or whatever kind of cell type you have in your brain. And this is where I'm really looking forward to see what's going on there. And we are doing a lot of research on this just to see how these neurons that we get out of this inducible pluripotent stem cells from our patients would look like. Just where is the ATP1A3? It's distributed on the surface of the neuron, of the axon of the neuron, and in the synapse, just like in wild type, so just like in an unaffected neuron derived from this inducible pluripotent stem cells. And when we see structural differences, that would be nice, but I'm more interested in functional differences, because we really want to see what this neuronal network is doing, bearing one of the patient mutations. And I think when we can influence this to the level that we will see in a wild type cell, so in a cell not affected by a mutation, that would really help us to find a cure. Of course, you always have the problem of the so-called blood-brain barrier. So if you give a medication, just don't go to the brain. And so you have to use some tricks to get it into the brain, because there it is needed. But I think progress on this is made a lot, and that's why I think we will find something. Somehow really fascinated by these patient organizations, because before I was in the field of alternating hemiplegia, I worked a lot in another rare disorder group, a neurometabolic disorder group, which is called paroxysomal disorders. And of course, these kids are really severely affected, and they die in the first 2 to 3 years of life regularly. But I tried to set up patient foundation for these kind of patients, and I was not successful. And I'm really surprised and excited by the power of the patient societies and how they emerge, how they work together, and how helpful they are. In Germany, we have the good thing that are able to raise money for this, for basic research for this rare disorders. But and so we don't need the money, but we of course need the support, and we need the information from the patient, and we always keep on asking questions on and on and on, and it's nice that they don't get exhausted from this, that they are willing to support even though they know that their own children might not benefit from this. And this really engages me. That really excites me.